Good afternoon, everybody. My name is Robert Puentes. I'm the president and CEO of the ENO Center for Transportation. And today is the latest in our series of webinars, The Road to Recovery. This webinar series focuses on leadership lessons and transportation strategies for our post-COVID future. You can tune in on Wednesdays to hear and interact with leaders and experts from across the transportation space who will share their firsthand knowledge, experience, ideas, perspectives on the road to recovery. And today, I'm really happy that we have three stellar experts with us today. We're going to have a panel kind of discussion. Let me just introduce them quickly. We have Shima Hamidi. She is the Bloomberg Assistant Professor of American Health at the Johns Hopkins Bloomberg School of Public Health. She's also a former ENO Fellow. We have Reed Ewing. He's Professor of City and Metropolitan Planning at the University of Utah. And Sadi Sabori, who is also a research assistant also at the University of Utah. This panel is going to focus on their recent paper, which was just published in the Journal of the American Planning Association, entitled "Does Density Aggravate the COVID-19 Pandemic?" For those who are joining us live, you can submit questions using the questions function on the webinar website. We invite you to submit questions anytime. You don't have to wait until the presentations are done to submit questions. So as the nation continues to deal with this obvious global pandemic, and as cases continue to spike here in the United States, we have seen this growing narrative seemingly declaring the death of cities and urban spaces. The simple case seems to be that if social distancing is an important way to prevent the spread of the disease, then the degree to which people are close to one another, or on the flip side, the degree to which people are isolated from one another, really matters. But as we all know, this virus, the way we've dealt with it, the policy response, the prospects for the future is anything but simple. So that's why I'm thrilled that the authors have agreed to participate on this webinar with us here today. They're going to discuss their research and their findings, and then we will take your questions. So again, thank you all for being here. Let me first turn it over to Reed Ewing.
Okay, well, thank you so much. So I move to the next slide, please. So we've already introduced the threesome, the three co-authors. I just want to say two things. One, thank you, Eno and Rob in particular, for giving us this opportunity. And to Shima and Sadi, it's been such a pleasure working on this project. We set out to be the first to address COVID in the context of planning, and we hustled, and the Journal of the American Planning Association put us through an expedited review, and our paper is now out and available for downloading. So the first slide simply makes the point: to model something, you have to be able to measure it. Next slide. We've been measuring sprawl and compact development. They're alternative ends of a continuum, compact being high density, integrated uses, strong centers, downtowns, town centers, and well-connected street networks, and sprawl being the opposite, low density, segregated uses, lack of strong centers, and sparse street networks. We've been measuring sprawl since the early 2000s. You see our original paper, that's from 2002, measuring sprawl and its impact. Next slide, please. So we put out the report, and it got a lot of attention. And it was because we were the first to look at public health from a planning perspective, specifically a quantitative study of sprawl and its antithesis, compact development, versus physical activity, obesity, body mass index, and downstream impacts on health. And that came out in 2003. Then after that, we had a series of papers, ourselves and others, linking sprawl or compact development to different outcomes. And notice a number of them, Rob has asked that we draw connections to transportation, and you see a number of them: traffic fatalities, air quality, obviously, relates to transportation. Emergency response times, teenage driving. So between about 2003 and 2000 and maybe 10 or 11, all these studies were done using our sprawl metrics. The next slide, please. 2014, with funding from the National Institutes of Health, we updated our sprawl metrics and our analyses of outcomes associated with sprawl. By that time, Hickory, North Carolina, was the most sprawling metropolitan area in the country, and New York was the most compact. It had been the most compact in 2002 as well. And you can really see density. Going back to this, you can really see the effect of density. The grayish tone signifies the built environment. Green signifies the natural environment, farming, etc. The difference couldn't be starker between New York and Hickory. And so we, next slide, please. We redid our analyses from 2003 in a series of articles. This one was in the Journal of Planning, Education, and Research. Shima was the lead author, as she is on the COVID-19 paper. And what we found in this paper is that compact development, again, the antithesis of sprawl, dense development as opposed to low density sprawling development, was related to transportation outcomes. The percentage of people using transit to get to work, the percentage walking, the average drive time, and vehicle ownership in this particular paper. And we looked at each of the individual dimensions of sprawl, density, mix, centering, and street connectivity. We looked at each of the dimensions and how it affected outcomes, transportation outcomes. Next slide. This is another study that is related to transportation. We redid a 2003 analysis looking at how urban sprawl affects motor vehicle crashes. And what we found, and not surprisingly, is that sprawling places have more fatal accidents per capita, and compact places have fewer. Going back to that slide, so we found what we thought we would find, this relationship that exists between compact development and fewer fatal crashes. And that's probably because these compact places have lower VMT per capita, people drive less, and they probably drive at lower speeds. The article explains the rationale for that relationship. Next. We found in another transportation-related study that people living in compact places spend less on transportation, significantly less than those living in sprawling places. They own fewer cars, they drive fewer vehicle miles, etc. Housing is more expensive in compact places. Transportation is less expensive, and the net effect of the two largely cancels one another out, but there's a slight advantage to compact places. So that's another transportation-related study. Next, and this is a segue to our COVID study. We went back and we looked at the relationship between urban sprawl or compact development, physical activity, obesity, and morbidity, things like diabetes, type 2 diabetes, hypertension, etc. And once again found that compact places have lower BMI. So controlling for all other variables that we could measure, like race and age and gender and so on, we found that living in compact places, people tend to weigh less than they do in sprawling places. And that is the segue to this study. Next slide, please, of the relationship between compact development measured in terms of density and both the rate of infections due to COVID-19 and the rate of death, the death rate or mortality rate due to COVID-19. And I'll turn it over now to Shima.
Good afternoon. Thank you, Reed. And I would like to also thank Eno for giving us the opportunity to present this study. As Reed mentioned, this is the natural extension to our previous studies on the link between the built environment density and health outcomes. It's published in the Journal of the American Planning Association a couple of weeks ago. And it looks at the relationship between density and the COVID-19 pandemic outcomes. It's one of the first studies, peer-reviewed studies on this topic. It's a national study of 913 counties in the US. These are early findings, and they were kind of unexpected to us. And we would like to share them with you, so stay tuned. Next slide. But the motivator behind this study was, the extensive stories in news media outlets and conversations among practitioners, and even in the academic context, that really blaming density for the rapid spread of the COVID-19 in the US and in New York City, and referring to the suburban sprawl as the United States secret weapon against coronavirus in some stories. Here is a quote from one of these stories that was published in New York Times that says that the pandemic has been particularly devastating to America's biggest cities, as the virus has found fertile ground in the density that's otherwise prized. Next slide. In another story in CNN quotes Governor Cuomo from the state of New York, who said, "It's very simple. It's about density. It's about the number of people in a small geographic location, allowing that virus to spread. Dense environments are its feeding grounds." And these stories have been already making impact. Recent surveys are showing that people are already considering to leave cities and move to suburban and urban areas. Even millennials who were always the fan of compact, mixed-use, walkable places now are considering to leave the city in fear of pandemics, and businesses and offices are following them. The question we are asking is, to what extent through analysis and statistical modeling with data will provide evidence on this news. And in absence of data analysis, by just looking at the correlation or observational cases, really there is no way to make a conclusive conclusion. Next slide, please. But before going to the study, I would like to present three sets of concepts that most often are confounded with each other. The first one is looking at counts versus rates. Many of those stories that you just saw in previous slides are looking at counts, higher number of infections or death in larger cities. But if you look at the per capita rates instead of counts, which is the map on the bottom left, you will see the landscape of special distribution of infected cases are totally changed. And that is a much more informative measure than just counts. It's a measure that's relative to population. And that's what we are using in this study. Next slide. The second set of concepts that are confounded with each other is density versus size. So here is, you see the map of New York State and counties that are in New York State. The darker color represents higher density, lighter color represents low density counties. And you see two metropolitan areas in the state of New York, Albany, MSA, with a population of about 900,000, and New York, MSA, with a population of more than 2 times higher, about 20 million people. If you look at the counties, you see both of these MSAs have sprawling counties and compact counties, low density and high density. But specifically, if you look at an example of low density counties in New York MSA with a density of 518 and its counterpart, a county with higher density of 1100 in Albany MSA, you will see that the death rate of the latter, even though it's higher density, is much lower than the first case. And it really comes to the larger context of metropolitan size. You know, the relationships that these counties have with each other, the kind of social, economic, commuting relationships that they have that helps the virus to spread out, you know, to many places within the same metro. So our study also controls for this difference between the two. Next slide. The same set of confounding concepts are density versus crowding. You know, density is distinct from crowding or overcrowding. Crowding could happen when a large number of people gathered closer together. Even at high density areas, crowding is limited only to specific venues such as bars and restaurants and schools, you know, sport events, airports, supermarkets, or even on the beaches. By definition, crowding could happen even at very low density areas at all of these venues. And this is what you see in these photos. You know, they are not dense places, but they are crowded. And it's important to distinguish between the two when we are talking about density and COVID-19 or any other pandemics. Next slide. If you look at the context of previous pandemics and what previous studies, you know, tell us, you see that it goes back to 1918 Spanish flu, and there are studies that are showing the relationship between density and, you know, pandemic for, you know, going back to 100 years ago. And a follow-up studies, mostly non-US studies, looking at the more recent pandemics like H1N1 and Ebola. But one thing is common between all of these studies. The findings are mixed. There are studies that are saying the relationship between density and pandemic spread is insignificant. Some others say it's significant and positive, and it really is confusing and inconclusive. The reason being, next slides, please, that the dynamic behind the pandemic spread are highly complex. There are so many factors and players. There's socio-demographic characteristics, there's social inequalities, and, you know, racial disparities, income disparities, access to resources, workforce policies, and job security that led people to telework or have days off, sick days. Travel and tourism and the level of international and national connectivity, healthcare facilities and infrastructure, and measures of social distancing that different places adopt all play a role. And if you want to look at the relationship between density and COVID or any other pandemic, you got to control for these factors and have them included in your analysis, which is what we've been trying to do in this study. Next slide, please. So I would turn it to Sadi to present the our methodology and research process.
Okay, thanks Shima, and thanks Ino for providing us this opportunity. So in terms of modeling approach, we use structural equation modeling, or SEM, and the reason for using SEM is that it is capable of controlling for moderators, mediators, and confounding variables. In this study, we have COVID-19 infection rate as a mediator. By that we mean that a variable like density, county density, is directly related to mortality rate, COVID-19 mortality rate, but it's also indirectly related to the COVID-19 mortality rate through this infection rate. So intuitively, people think that denser counties will lead to have a higher COVID-19 infection rate, which will lead to higher COVID-19 mortality rate. So what are the confounding variables? Shima briefly talked about them. We try to control, create like 20 or 30 different variables. These are the latest list of variables that we use as a confounding variables. In terms of socioeconomic characteristics, we try to control for percentage of minority, percentage of adults with education after high school, and percentage of population age 60 plus. In terms of connectivity, we had two measures. One, we called it internal connectivity, which was metropolitan size of population. And also in terms of external connectivity, we have employments per 10,000. Some other variables like days since first case was confirmed, and also we had a measure of crowding, which was more than 1% per room. In terms of county compactness, we control for activity density, and by activity density, we mean population plus employment per square mile. And we had a measure of social distancing, which was a percentage of staying at home, which we borrowed from the Maryland Transportation Institute. And related to health characteristics, we have primary care physician rate, percentage of adults currently smoking, air pollution, ICU beds per 10,000, and COVID-19 testing rate. And here is the map of counties. As of May 25th, there were 913 counties in the United States that had metropolitan counties that had at least one confirmed death due to COVID-19. In this map, you cannot see a couple of counties in Alaska and Hawaii. But again, our unit of analysis was county. This was the most disaggregated level of data, which at the national level we could find from the Johns Hopkins website. So our outcome variables are natural log of confirmed cases of coronavirus per 10,000 population, and also natural log of confirmed deaths. The reason that we use natural log is if you look at the two plots on the left side, the top left is virus rate, the histogram of virus rate, and the bottom left is the histogram of death rates. As you can see, both of them are skewed to the right, and when we took the natural log, both of them became almost normally distributed. And this is one of the assumptions that when we do SEM, it's better our data to have normal distribution. And this is our final causal path diagram. As you can see, some of the variables are directly related only to virus rate, like employment rate. Some of them are only directly related to death rate, like ICU bed rate. And some of them are related to both virus rate and death rate, and they have indirectly related to death through the mediating effect of virus rate. With that, we go back to Shima.
Thank you, Sadi. Turning into the results, the interesting part. Here you see the relationship between the variables we had in the model and COVID-19 infection rate. The green color shows the relationship was significant and positive. Red color shows it was significant and negative. And the gray color, the gray arrow shows there was no significant relationship. As you see, in most cases, we find that the other control variables or confounding variables have the expected relationship with the infection rate. But our variable of interest, density, you see that it's not significantly related to the COVID-19 infection rate. Why that could be the case? We think this is possibly because density plays two conflicting roles, which could cancel out each other. You know, on the one hand, density increases contacts with other people and likelihood of the transmission of diseases. And on the other hand, people in compact counties have fewer and shorter trips most often. They are better equipped to follow social distancing advisories due to better access to home delivery grocery shoppings. Even pre-pandemic era, they do more online grocery shopping than their counterparts in suburban areas. And they are also more likely to voluntarily engage in social distancing, being more cautious about the threat. The other variable of interest, metropolitan size or metropolitan population, you see that it is positively and significantly related to COVID-19 infection rate. Higher, larger metro areas lead to higher infection rates. In fact, larger metropolitan areas are the ones that are more likely to exchange tourists and business people with each other and with other parts of the world, and thus increasing the risk of cross-border infections. If you remember the two maps that I showed you, Albany versus New York, we found that metropolitan areas like New York are with a higher number of counties tightly linked together through economic, social, and commuting relationships are the most vulnerable to the pandemic outbreak. Next slide, please. The second model looks at the COVID-19 mortality rates. And you see that the activity density's relationship to mortality rate is negative and significant, meaning that COVID-19 death rates are lower in denser counties, and that in a higher level of significance. This is likely due to better access to healthcare facilities, such as testing facilities, particularly at early stages of the pandemic, but also to better healthcare infrastructure, such as the number of ICU beds and intensive care infrastructure. Again, metropolitan population relationship to mortality rate is positive and significant, which again emphasizes that larger metro areas are more vulnerable to the pandemic outbreak. Next slide, please. I'm sorry, someone is testing the alarm fire in my apartment today. So I sometimes get random noises on the background. Looking at the direct and indirect relationship together, add them up to have the total effect of these variables on the COVID-19 mortality rates, you will see the results in this table. Because we use the log version of activity density and metropolitan population, the coefficients are showing the elasticities, which means doubling activity density results in about 11% decrease on the COVID-19 mortality rate, and doubling metropolitan size results in about 21% increase on the COVID-19 mortality rate. Next slide, please. This was a cross-sectional study. So we looked at these relationships over time, several times, a dozen times, and the last one was last week, to see if the results are consistent, and the results were consistent. But we want to also look at them longitudinally over time to track down the daily changes in the COVID-19 mortality rates and infection rates, and track down the changes on people's daily travel, social distancing advisories, other factors, and county level variables, and see if the relationships are kind of similar or consistent between the cross-sectional and longitudinal. And this is the study that was just accepted for publication. We are working on the proofs and will be out in a couple of weeks. And we found that in most cases, the results are consistent. Larger metropolitan areas are associated with significantly higher COVID-19 infection and mortality rates, and county density is associated with significantly lower death rates, which is consistent with the first study, but also associated with significantly lower infection rate when you look at the relationships longitudinally. Other set of variables were the same between two studies and were again ended up with expected signs and significance in most cases. But we think the two together will come even with the stronger story of telling us how density impacts the severity and mortality and spread of the COVID-19 pandemic. Next slide, please. So I would turn now to Reed for our to share with you our final thoughts and conclusion remarks.
Thank you, Shima. And just a couple of things before I summarize our results. The paper that Shima referred to is already out. It's in a journal called Health and Place, which is a health journal as opposed to a planning journal. Another point I'd make is as the COVID-19 virus spreads like wildfire in the Southeast and the Southwest, as it is doing now, the new epicenters are not New York City, but rather places like Houston. We would expect our results to get even stronger, those results that Shima described. She has already mentioned the first point in this slide, that when adults and millennials in particular were surveyed in May 2020, they were considering moves to suburban and exurban areas to get away from COVID or reduce the likelihood of a virus infection and ultimately death. So that's a point that we've made before, and I'm reiterating. Also, office vacancy rates have increased much more in downtowns than they have in suburban areas, suggesting that not only the residential market, but the commercial market will be affected by COVID-19. And then the final point is our empirical finding that, and the way I'd like to say it is that the planners and others, policymakers, have had a dominant paradigm for the last 30 years, as long as I've been in planning, and it's that compact places are a good thing. The dense, mixed-use, walkable places are a good thing. This COVID-19 pandemic and earlier the 9/11 terrorist attack, and before that the Cold War threat of nuclear attack has called people to question whether compact development is actually a positive thing or maybe a negative thing. It's better to disperse population, and that's not our finding in this this particular study. So I'm going to end with a quote from the paper, the JAPA paper, which is available free of charge online if you want to read it. The fact that density is unrelated to confirmed virus infection rates and inversely related to confirmed virus death rates is important, unexpected, and profound. It has implications for community design, regional planning, transportation expenditures, urban redevelopment, tax policy, congestion pricing, smart growth, affordable housing, and nearly every other front burner issue important to planners. So planners don't have to abandon the paradigm that they've been operating under in recent, particularly the last 20 years. The compact development has more benefits than cost. They can adhere to that particular paradigm with some confidence. But I'm going to end by just saying our findings in our title, paper title, refer to early results. It's very hard to predict how things will play out as the pandemic wave one continues, and then ultimately we have a second wave of the pandemic in the United States. So we encourage others to do research on this particular issue. So thank you so much on behalf of the three authors, and thank you again to Eno.
Thank you,
Well,
Reed. And
take questions.
yes, and my thanks to the authors too. It's really tremendous work, and thank you for doing it so quickly. I'm glad that the APA and the folks at the journal helped fast track this to get it out, because it is important. And judging from the questions and judging from the comments that folks have already sent in, it's clearly top of mind for a lot of people. This whole issue of the definitions, I think, really matter. The difference between density, which is a measure of place, and crowdedness, which is a measure of people, I think really matters. And clearly, as Reed was saying, it's just incredibly complex. I'm getting to a whole bunch of questions. A lot of folks have methodological questions. I'm going to try to bundle those together. But let me just kick off with a general question if folks are wondering on the transportation side. It really builds off of what you were talking there at the end, Reed, about planning. So from a transportation perspective, right, the transportation, especially public transit, is very much in the narrative, because public transit actually requires there to be crowded conditions. That's when it's really efficient and when it's really effective. Anything you could say about the role of public transit? I know you didn't study that here directly. That might be coming up later, but how does that play into this?
Yeah, Shima is the best respondent.
Sure, I will be happy to. Public transit is another place that could be a source of crowding and potentially contribute to, the COVID-19 infection. But it's also the one that's subject to potentially conflicting roles. Public transit is typically the one that's also the one that is the earliest that people get cautious and avoid, and make sure that they're following up the 6 feet distance with the next person, or avoiding public transit at all. I just want to mention quickly the follow-up study that is ongoing study. We are doing it with New York City, the subway system in New York, and the density and other factors, the level of crowded housing and the level of crowded businesses. And that study is at a smaller geography, zip code level. And so far, our findings show that subway is not a significant contributor to the infection rates. Density is not either. But what is a significant contributor is crowded housing. And the other one is crowded businesses, points of interest, where places that can attract a large number of people, like bars, restaurants, the one that we showed in this photo. And those are the ones that have a much more significant contribution to the spread of the pandemic than public transit.
Great. And then a couple other questions. One, I think you're actually starting to get to this maybe there at the end. Folks are wondering, and this is probably from popular reporting, about infection rates and spreads in places like prisons and nursing homes. Does that factor into either of these analyses? How do you respond to those particular places as this relates to this?
Again, Shima.
Sure. Those are very important, particularly nursing homes. I was reading an article from New York Times. I was saying 43% of the mortality rates or the counts are coming from nursing homes. That is that's the kind of variables that you got to look at it at a smaller geography through case studies for specific cities or metro areas. This study was national, and we didn't have there's not such a data as the number and distribution of nursing homes and their characteristics that could lead to this crisis. So, but I would encourage future researchers to look at the nursing homes, meat processing places, and again, places that could be the source of crowding, particularly for vulnerable population, such as low income or elderly.
Yeah, and I'll add one thing to that. We did control for the age distribution, specifically those 60 plus, and found that while they're not more likely to get infected, they are much more likely to die if they get infected. And the reason they are not more likely to be infected is they really don't get around as much as younger people do. But once they get the virus, their probability of death is much higher. So that relates to nursing homes.
Yeah, and that's just one sentence. That's kind of the pattern that you see in the nursing homes. The infection rates there are not higher necessarily, but the mortality rate is much higher than just the overall average.
Sure. That would make sense. That actually gets maybe, I think, to a couple of, there's several questions about the staying at home variable. Can you talk about that, the stay at home variable, that is both its positive correlation on increased infection and increases in mortality?
Sadi?
Yeah, this variable comes from Maryland Transportation Institute. They have created this variable in a way that if it's more than 0.1 mile, if a person moves less than that, they consider that as they stay at home. And the way that we try to control for this variable was trying to average this percentage. This data is daily basis. So we try to control for this variable by averaging this percentage of staying at home since the first confirmed case was detected in each county till the last day, which was May 25th.
Yeah.
In terms of why it has the positive sign, I think Shima can answer that better.
Sure, Sadi. So this is, I want to point to the fact that, our JAPA paper is a cross-sectional study, and it shows the association between the two. And that's kind of in agreement with what previous studies are found, that in dense places or in places that have the higher mortality rate or the higher infection rate, people are more cautious and more likely to follow up, with the social distancing advisory. So the correlation between the two are positive, but it doesn't necessarily mean the causation. In our follow-up paper that was longitudinal, we find the same relationship, but we think the one thing that we did not do on that study and could be done in future studies is to control for the time lag. From the time you do social distancing, it will take 1 or 2 weeks to show up, the impacts on the ground in terms of infection, and another 2 or 3 weeks to show up the impacts in terms of the death rates. And looking at this, the time lag will lead to have a more inclusive conclusions.
One very quick point related to what Shima just said. We acknowledge this as a limitation of the cross-sectional analysis. It's very possibly due to reverse causation. People stay at home because the virus rate is higher, as opposed to the virus rate being higher because people stay at home. So we acknowledge that as a limitation, but we didn't feel we could ignore it, these policy measures that have been taken. We felt we needed it in the model and so included it.
So did you have something on that too?
Excuse me?
Oh, I thought today was going to jump in there too. Nope.
Yeah.
But that actually, that a couple of those questions are all bundled around the time lag. So I'll skip those for now, and then kind of address some of these questions. A lot of folks have questions of the data on race and as a variable. Let me just ask one here. Can you explain why the % of African Americans in the county correlates with a higher infection rate but no effect on mortality rate?
Sadi, do you want to do that or should I?
Go ahead.
Well, we think that for a lot of reasons, the infection rate is higher for Blacks. They, for example, are more likely to be in service jobs where they can't stay at home and telecommute. We think they are more likely to have pre-existing conditions that would make them vulnerable to infection. We're not sure why the death rate isn't higher for them. One would have assumed as much, although the human body is the human body. Once you're infected, there doesn't seem to be much difference across the races in the fatality rate or the mortality rate. So that's one of those questions for future research. And I'll just say this, if I could, Rob, we expect there's going to be a flood of additional research on this subject. It's the reality we live in right now. COVID-19, if you watch the news on TV, it's the trending topic almost every night. And so there'll be a lot of additional research, and we think of ours as our paper is very similar to that first paper on sprawl and obesity that we issued in 2000 or published 2003, which led to just a flood of additional research and insights. And so your question will be answered ultimately.
Yeah, that was from 2003. That makes me feel very old. But we're just at about time here, and I want to be respectful of everybody's time and the presenters here. We really did come close to answering a lot of these questions. That's just, I mean, really just a flood of things. Particularly at the there's two types of questions. A lot of data questions at the beginning when we were going through the presentation, and now a lot of policy questions here at the back end. A lot of questions about the political environment in some places, the policy choices that some governors are making, people's choices around wearing masks and things that I know the study didn't get into. But as Reed says, I'm sure there's going to be tons of more work on this. I encourage everybody, first of all, to read the paper. As Reed said, it's going to be up. It's up on the web. We can provide a link to that on our website, so you can check that out as well. But I'd encourage folks to take a look at what's in this piece of research, understand what it's trying to do, and then recognize, as Reed said, that there's going to be a slew of this stuff, I think, coming out over the next few months and years, quite frankly, because we haven't even begun to scratch the surface yet. But I really appreciate you scratching the surface here with us today. This is a great entree point into this. And I want to thank everybody for your participation in joining the webinar. A recording of this webinar is going to be up on ENO's YouTube channel later today. There'll also be a link to it on ENO's website. That's www.enotrans.org. While you're there, you can find out about all of our upcoming webinars. We have one next week on why transit agencies need the public to take ownership of the transit experience, actually addressing a whole bunch of the questions that I think came across here today. And when you're there, you should also check out ENO Transportation Weekly. It's our weekly publication on all things transportation policy and practice. So just again, my deep thanks to Shima, Reed, and Sadeh for this excellent presentation, for all of the work that you've done here, and much more to come. So thank you everybody for your participation. Stay safe. Have a great holiday weekend.
Thank you.
Thank you, Rob.